Welcome to Fertility Doc Talk. I'm your host, Dr. Kaajal Abrol. I'm a board-certified obstetrician-gynecologist and fertility physician based in Toronto, Canada. My goal is to educate patients, partners, and the public on fertility and to destigmatize infertility. Through this podcast, I aim to increase knowledge and awareness about reproductive health to empower people to make informed decisions about their own fertility. Welcome, everyone. In this episode, we are talking all about endometriosis, a chronic progressive condition in which tissue that is similar to the inner lining of the uterus, the endometrium, grows outside of the uterus. This tissue can implant in your ovaries, on your fallopian tubes, on your bowels or your bladder, on your diaphragm, appendix, or various other organs throughout the body. Endometriosis is thought to affect approximately 10 to 15% of reproductive age people with ovaries, and 25 to 50% of people with ovaries who have fertility challenges. The cause of endometriosis is not known for sure. There are a few theories on how it may develop. 3 common theories that have been proposed are: 1. Retrograde menstruation. This is when menstrual blood containing endometrial cells flows through the fallopian tubes and into the pelvic cavity at the same time that blood is flowing out of the body during menstruation. Retrograde menstruation may then result in endometrial cells implanting outside of the uterus, where they can then grow. 2. Cellular metaplasia. This is when cells change from one form to another. The theory is that cells outside of the uterus change into endometrial-like cells and start to grow. And 3. Stem cells. The theory is that stem cells may give rise to endometrial-like cells, which then spread through the body via the blood and the lymphatic system. Overall, it is thought that the endometriosis cells cause a chronic inflammatory reaction that may result in the formation of scar tissue within the pelvis and in and around other parts of the body. There are a few different types of endometriosis lesions that have been described. Superficial endometriosis, which refers to superficial lesions found in the peritoneum, the tissue covering all the pelvic organs. Ovarian endometriosis, which refers to ovarian cysts filled with endometriosis cells, usually looking like thick brown fluid, and as such, these cysts are often called chocolate cysts. Deep infiltrating endometriosis, which refers to deep lesions found within tissues and organs, like the space between the rectum and the vagina, or lesions in the bowel or in the bladder. And extrapelvic endometriosis, which refers to lesions found outside the pelvis, away from the reproductive organs. This is quite rare and includes the chest cavity, the abdominal wall, and the diaphragm. Common symptoms of endometriosis include painful periods or dysmenorrhea, pain with intercourse or dyspareunia, and pain with bowel movements or dyschezia. These are 3 classic, commonly mentioned symptoms, but other symptoms include chronic pelvic pain, pain with urination, heavy bleeding, bloating, diarrhea or constipation, and infertility. It's important to note that the extent or seriousness of the pain may not correlate with the extent of endometriosis growths in the body. So, you may have a small amount of endometriosis tissue with really bad pain, or a lot of endometriosis tissue with little or no pain. Now that we have reviewed the basics of what endometriosis is and how it may arise and the symptoms, let's talk about diagnosing endometriosis. A diagnosis of endometriosis will usually start with a thorough history to see if any relevant symptoms are present. A pelvic ultrasound is often the next step. Although endometriosis is not always seen on ultrasound, unless there are obvious endometriosis cysts or lesions, it is a good next step. If there is a strong suspicion of deep infiltrating endometriosis on history, MRI may also be used, as it can be more helpful than ultrasound to pick up deep endometriosis lesions or plaques in the pelvis. Laparoscopy has been said to be the gold standard for diagnosis of endometriosis. In fact, once upon a time, most fertility patients would undergo a diagnostic laparoscopy to see if endometriosis was playing a role. This is not done routinely nowadays because when you weigh the risks of surgery versus the benefits or improved pregnancy rates with fertility treatments, surgery for diagnostic purposes does not show a clear benefit. More recently, advanced ultrasound imaging is becoming more available to help in the diagnosis of endometriosis. This is not as readily available in Canada right now, but hopefully this will change with time. From a fertility perspective, it is important to know whether endometriosis may be playing a role, regardless of whether it is suspected or confirmed, as endometriosis may affect fertility in a few different ways. 1. Function and structure of the fallopian tubes. This is because scar tissue in and around the tubes may block the tubes or affect the normal function of the tubes, making it difficult for sperm and egg to meet and fertilize, and have an embryo transported to the uterus for implantation. 2. Egg quantity. This is because the presence of endometriosis cysts may take up space in the ovaries and thus impact ovarian reserve or egg quantity. 3. Egg quality. This is because the inflammation caused by endometriosis is felt to have an impact on egg quality, which in turn may impact pregnancy rates. And 4. Implantation. There are some thoughts that endometriosis may affect the lining of the uterus and impact implantation. Treatment for endometriosis can be divided into options for those trying to conceive or for those who are not trying to conceive. For those individuals who are not trying to conceive, treatment is largely focused on managing pain and improving quality of life. Main treatment options include medications or surgery. Examples of medications that may be used to help treat endometriosis include pain medications like NSAIDs, hormonal birth control such as the pill, the patch, or the ring, progesterone-only medications like an intrauterine device or IUD, or a progesterone tablet or injection, or other injectable medications such as a gonadotropin-releasing hormone agonist like leuprolide acetate, or a gonadotropin-releasing hormone antagonist like elagolix. Surgery for endometriosis is often considered when medical treatments have not helped to improve symptoms. Surgery for endometriosis can be quite varied and really depends on the extent of disease that is found. Surgery is generally done laparoscopically and may involve removing any endometriosis lesions or plaques that are found, removing any scar tissue that is developed, and removing large ovarian cysts. Surgeons will often classify endometriosis noted during surgery from stage 1, which is mild endometriosis with superficial lesions, to stage 4, which is the most advanced endometriosis with large ovarian endometriosis cysts and deep infiltrating endometriosis. For those trying to conceive, medical treatments for endometriosis are not ideal, as most options prevent pregnancy, and others are not safe for pregnancy. They are, however, sometimes used before a fertility treatment cycle to try and suppress endometriosis and potentially help egg quality or implantation. The role for surgery for endometriosis in the fertility patient is more complex. Surgery may be used to help treat the fallopian tubes if a hydrosalpinx is found. A hydrosalpinx is where a fallopian tube is blocked on the end farthest from the uterus, and then the tube fills with fluid. This fluid has been found to significantly decrease pregnancy rates, and so it is recommended to remove these fallopian tubes before trying to conceive. Surgery may also be used to remove large endometriosis cysts from the ovaries, although such treatment must be individualized, as surgery on the ovaries can also negatively impact ovarian reserve. Benefits must outweigh the risks before proceeding with surgery. Fertility treatment is a good option when endometriosis is suspected or known, and you have not been able to conceive naturally. This could include controlled ovarian stimulation and intrauterine insemination, or IVF. IVF is often encouraged in those with endometriosis because it gives the highest chance of pregnancy overall and the possibility of freezing surplus embryos, both of which are advantageous for family planning with this known progressive condition. Egg freezing is also potentially a good option for individuals with endometriosis who are not ready to conceive now but want to preserve their fertility before endometriosis may impact it further. Now let's take a few moments to go through some common questions I hear about endometriosis so you can better understand this diagnosis. First, can endometriosis be cured? Endometriosis is a chronic condition. Unfortunately, it cannot be cured. That said, it can be treated, and as mentioned, there are several treatment options which can help to minimize or eliminate symptoms to help improve quality of life and fertility, depending on the goal. Another common question I hear is, my sister has endometriosis. Does this mean I will have it too? This is a good question. In short, not necessarily. But there does appear to be an increased risk in individuals with a family history of endometriosis. So it's something important to discuss with your healthcare provider. The last question I want to address is, I have endometriosis and was told I will not be able to get pregnant. Is this true? This is not true. People with endometriosis can conceive. And as discussed, it may impact fertility to varying degrees. I think it's all about seeing a fertility specialist early if you know or suspect you may have endometriosis, to have a workup, identify any current factors that may be affecting your fertility outside of the endometriosis, and then making a treatment plan to optimize your short and long-term fertility goals with this diagnosis in mind. So there you have it, all about endometriosis, what it is, how it is diagnosed, and how it may be treated. It is important to understand the relationship between endometriosis and your fertility, so you can seek appropriate help to try and conceive, if needed, when you are ready, or so you can consider fertility preservation options like egg freezing now. I hope this episode was useful in allowing you to better understand the complex disease that is endometriosis, so you know how this condition may affect your fertility and how it can be managed and treated. That's it for this episode of Fertility Doc Talk. I really hope you enjoyed listening and learning and feel empowered about your reproductive health. If you enjoyed this episode, please remember to subscribe to the podcast and tune in to our next episode.